A very good afternoon, one and all. Today, we are going to discuss something about the recent advances in the administration of surfactant for treatment of newborns with respiratory distress syndrome. I'm Dr. Aparna, Chief Neonatologist at KIMS Cuddles, Kondapur. And in this presentation, we shall be discussing about what is the rationale behind the use of surfactant, what are the different timings of surfactant replacement therapy, including prophylactic, early rescue, late rescue surfactant replacement. We shall be discussing different types of surfactant, natural versus synthetic, and different techniques of surfactant administration, including Ensure, MIST, and LISA, and newer techniques such as use of laryngeal mask, airway, and nebulized surfactant, and some non-RDS indications for the use of surfactant in neonates. A little bit about the history of surfactant administration might be interesting. As early as the year 1929, researchers had performed animal experiments to ascertain the presence of surfactant in the lung, which was responsible for preventing alveolar collapse. It was found that when animal or rodent lungs post-mortem were filled with saline, removing the concept of the air-liquid interface, the compliance was found to be much higher. That is, the unit increment in volume achieved for unit increment pressure was much higher when compared to the normal air-filled lungs, which allowed the presence of an air-liquid interface, leading to the understanding that surface tension was a physiological concept that was responsible for airway collapse, and a decrease in surface tension is necessary for adequate lung expansion. Researchers, including Avery and Mead, had concluded that hyaline membrane disease that we see in preterm neonates is associated with the absence or the late appearance of surfactant, which in normal subjects is capable of attaining a low surface tension when the lung volume is decreased. However, it required a dramatic event in the form of the death of the then US President the John F. Kennedy's second child, Patrick Kennedy, who was born preterm at 34 weeks with a birth weight of around 1800 grams due to RDS. And this death actually channeled a lot of enthusiasm and interest for clinical studies that involve the administration of surfactant replacement therapy in human newborns. So this increased public awareness and stimulated further research. And finally, the researchers from Japan, Fujiwara and his group, published the paper in Lancet of their experience with first 10 neonates who received surfactant replacement therapy, which was followed by a rapid increase in oxygenation. As we can see in this graph, the PaO2s pre and post surfactant are depicted here. So when we break down the chemical composition of surfactant, it is a well-known fact that 80% of surfactant is a lipid or phosphatidylcholine, which is the phospholipid responsible for reducing surface tension, 50% of which is saturated phosphatidylcholine and 20% is unsaturated phosphatidylcholine. But at least 8% of the surfactant moiety is composed of surfactant proteins, surfactant protein A, B, C, and D. Particularly surfactant proteins B and C are very, very important for achieving surfactant effect because they facilitate the absorption of dipalmitoyl phosphatidylcholine into the air-liquid interface, which results in uniform distribution of surfactant across the lung. Now, preterm babies contain less saturated phospholipid and more unsaturated phosphatidyl inositol, which is responsible for respiratory distress syndrome because most of the surfactant property of reducing surface tension is contributed by DPPC. Now, how does surfactant actually reduce surface tension? We know that phospholipids, which are the prime component of surfactant, accounting for almost 80% of the molecule, are charged groups which interact with the water. So they have a charged moiety that interacts with the water, which is present in the alveolar atmospheric or air interface, and a non-polar group or a fatty acid moiety that extends into the air. So these molecules basically reduce the absorptive or the attraction property between the adjacent molecules of water that are present on the air-liquid interface. Thereby, they decrease the adherence between water molecules on the interface and hence result in a lesser tendency for the alveoli to collapse. And it requires a certain phase transition of the phospholipid bilayer in order to achieve this clinical effect. So coming to the actual clinical studies, having understood how physiologically surfactant is responsible for benefit in RDS, we look at some clinical data. This is from a systematic review which was published by the AIMS group in Journal of Perinatology in 2016, which looked at the effect of surfactant in low and middle income countries and found that from a series of observational studies and a few RCTs as well, the use of surfactant replacement therapy was associated with reduction in mortality as well as air leaks, even in low and middle income countries, as much as it was found in the high income countries, and hence was safe, effective, and also feasible. So, having understood how surfactant works by reducing the surface tension on the alveolar air liquid interface, we shall discuss something about the timing of surfactant administration. So there are two broad timings or indications of surfactant therapy. One is prophylactic surfactant administration, which is administered for a neonate even before clinical evidence of RDS develops, as early as possible within 15 minutes of birth, so as to achieve very uniform distribution of the surfactant across the lung, even when the lung fluid is present. And secondly, rescue surfactant administration, which is administering surfactant for a newborn with clinical evidence of respiratory distress, as indicated by signs of rapid breathing, tachypnea, retractions, grunt, and the presence of a substantial need for respiratory support defined by a minimum PEEP of more than 5 centimeters of water and an FiO2 requirement that has varied in studies between 30 to 40%. And this can be administered either early, that is within 2 hours of birth, or late, more than 2 hours of birth. Now, most studies have shown that prophylactic surfactant does not seem to have a major role in decreasing both morbidity as well as mortality, and it may, in fact, paradoxically increase the combined outcome of death or BPD by almost 12%. This is because probably few newborns who may genuinely not even require surfactant may end up getting surfactant with a prophylactic approach. And hence, even in newborns born at gestational ages below 28 weeks of age, it may be possible to adopt a selective approach for surfactant replacement therapy, which results in better resource utilization by restricting to rescue strategy. It may have better cost to benefit analysis, and the rescue strategy has been found to decrease the need for ventilation by almost 63% and the duration of mechanical ventilation by 3 days. The NNF recently came up with clinical practice guidelines in 2021 and had a whole chapter dedicated to the role of surfactant replacement therapy. They make a strong recommendation against the prophylactic administration of surfactant to preterm neonates, even at gestational ages less than 28 weeks. And they recommend that preterm neonates with RDS should first be stabilized on CPAP and should receive selective surfactant replacement only if indicated, as defined by clinical criteria based on the need for respiratory support. And clinicians may consider delivery room surfactant in a selected subgroup of neonates born below 28 weeks who may require delivery room intubation for severe RDS and who may not have received antenatal steroids. And it is therefore very, very clear that the role of delivery room CPAP becomes extremely important to achieve a selective approach for surfactant administration in extremely preterm neonates. So there is clear evidence to show that surfactant administration for neonates with signs of RDS and who satisfy the indications for rescue administration of surfactant therapy is a definitely better approach to optimize the utilization of surfactant and to achieve optimal reduction in the combined outcome of mortality and bronchopulmonary dysplasia. An approach of early ensure, which is intubation, surfactant, and extubate when compared to just continuation of CPAP, has been found to result in a trend towards a reduction in the combined outcome of mortality or bronchopulmonary dysplasia at 36 weeks of post-conceptional age, as we can see in this meta-analysis that was included in the NFCPG guidelines, including 7 randomized controlled trials, including 1,310 neonates with a relative risk of 0.88, although 95% confidence intervals are just crossing 1, with a tendency towards fewer neonates developing bronchopulmonary dysplasia at 36 weeks or death with the use of early rescue surfactant administration using the INSURE strategy, which is intubation, surfactant, and extubate. This strategy is also associated with a lower risk of air leak syndromes with, as you can see, a 55% reduction in air leaks or with relative risk of 0.45. When one sort of compares early versus late surfactant administration, again, most of these benefits remain true. This kind of forest plot shows us the comparison of studies which looked at early versus late rescue surfactant administration, and early rescue surfactant therapy was associated with a significant reduction in mortality, bronchopulmonary dysplasia, and air leaks. So all these cumulatively resulted in a net reduction in bronchopulmonary dysplasia with a risk reduction of almost 31%. So how can one predict or kind of detect the need for surfactant? The need for FiO2 or fractional inspired oxygen concentration more than 30% in the first couple of hours of life has been found to be one of the strongest predictors for the need of surfactant administration therapy, along with a need of PEEP or CPAP more than 5 centimeters of water in newborns born at gestational ages below 32 to 34 weeks of gestational age. Lower the gestational age of the newborn, the greater is the likelihood of the benefit of surfactant replacement therapy. But again, if we have seen that even in extremely preterm neonates, a kind of strategy to prophylactically administer surfactant is definitely not found to be useful. Using a higher threshold of more than 45% FiO2 to decide the need of surfactant has been definitely found to be detrimental when compared to lower FiO2, because a higher FiO2 threshold has been associated with a greater risk of developing a hemodynamically significant PDA, with the risk being almost 2 times greater when compared to using a lower threshold for deciding surfactant replacement. Likewise, the other benefits of using a lower threshold for deciding the need for surfactant include a lower risk of air leak syndromes by 54% and bronchopulmonary dysplasia by 57%. Now, having seen that an early rescue surfactant replacement therapy works more effectively than a prophylactic or late rescue surfactant replacement therapy, the effectiveness of surfactant, one must remember, definitely depends upon the use of a complete course of antenatal steroids, the optimal use of delivery room CPAP, ensuring that the lungs are already opened in the functional residual capacity, and avoidance of other concurrent morbidities, especially hypothermia, and prevention of oxygen toxicity by using an air oxygen blender, and prevention of infections. Most of the international bodies also agree with the NNF guidelines that there is a role for a selective approach for deciding the newborns therapy, as the American recommends surfactant born below mechanical ventilation with stabilization. Neonates who after birth may require significant need for rest earlier. The European also agrees recommendations endorsing rescue surfactant administration in neonates requiring FiO2 more than 30% with CPAP greater than or equal to PEEP of 6 centimeters of water. So most bodies seem to agree that surfactant must be reserved for preterm neonates having significant signs of respiratory distress syndrome as identified by a requirement of PEEP more than or equal to 6 centimeters of water and a FiO2 more than 30% to maintain saturations more than 91%. So for the clinician taking care of a preterm newborn or attending a resuscitation of preterm baby, If the baby is born less than 28 weeks and the baby satisfies one or more of the following criteria, such as prolonged delivery room positive pressure ventilation or the need for delivery room intubation, or is born with a gestational age less than or equal to 26 weeks, one may consider giving surfactant prophylactically, consider the greater benefit to harm ratio in this group. And on the other hand, if the newborn does not satisfy these indications, the newborn may simply be started on optimal delivery room CPAP, which may be continued with NICU CPAP, ensuring prevention of oxygen toxicity, prevention of hypothermia, and ensuring appropriate coverage with antenatal steroids. And surfactant may be given if the baby, after stabilization on CPAP, continues to require PEEP more than 5 or FiO2 greater than 30%, or if the newborn requires intubation for severe RDS. And as far as possible, if the newborn has good spontaneous drive, one tries to intubate, give surfactant, and extubate as early as possible. And however, if the newborn is born at a gestational age of 28 weeks or above, one must routinely try to stabilize the baby with CPAP. And if only and only if the newborn satisfies the criteria for rescue surfactant, then one go ahead with surfactant. On the other hand, if the baby requires mechanical ventilation, irrespective of the pressures, if the FiO2 requirement is more than 30%, one may consider giving early rescue surfactant and consider ensure or intubate surfactant extubate on an individual basis in newborns with good comfortable breathing with adequate respiratory drive and hemodynamic stability. So there is no role for prophylactic surfactant at all in this group at gestational age of 28 weeks or more, and try to provide CPAP as early as possible. And even if this baby is an outborn baby, one has to try and stabilize the baby on CPAP and provide CPAP during transport. Now, coming to which surfactant is found to be most optimal, there are various types of surfactant, starting from animal-derived natural surfactants, the protein-free synthetic surfactant, and the newer protein-containing synthetic surfactants. This is a table from the AIMS protocol book, listing down the different types of surfactants. So essentially, we have the natural animal-derived surfactants versus the newer synthetic surfactants. The natural surfactants can again be minced lung extracts, where the lung extract of the animal might be minced and treated with agents like chloroform before extracting surfactant, including Cervanta, which is bovine-based bovine lung extract, and Curacao, which is porcine lung minced extract, and surfactant, which is also bovine-based. On the other hand, we could have lung lavage extracts like Bless, bovine lipid extract surfactant, also called as NeoSurf, commercially available, and IntraSurf. The newer synthetic surfactants, which have surfactant proteins incorporated, have multiple types. There is leucinactant or surfactant, which has surfactant protein B analog, and recombinant surfactant protein C containing surfactant or venticute. And there are also newer third generation synthetic surfactant which have enriched synthetic surfactants. Now, this is a table comparing the different preparation techniques and the trade names of available surfactant molecules, and it also lists the concentration of phospholipids in different surfactant preparations that are available. Some of the commonly used types of surfactant include Cervanta, which is bovine lung minced surfactant, also known as Baractant alpha. It has 25 milligrams of phospholipid per ml, and the clinical dose that is recommended is 4 ml per kg, which translates into 100 milligrams per kg weight. Curacao for Poractant alpha is also available, which is something that has higher concentration of phospholipid at 80 milligram per ml, and a dose of 2.5 ml per kg translates into a phospholipid dose of 200 milligrams per kg. Lung mince extracts typically contain less than 10% of surfactant protein B that is found in the lung wash extracts. And none of these natural surfactants still contain surfactant proteins A and D. This is something to be remembered. So now, which is better among the animal-derived natural surfactants versus the protein-free synthetic surfactants? Without doubt, the earlier Cochrane review published in 2015, which looked at a meta-analysis of RCTs comparing the two, found that animal-derived natural surfactants are definitely better, as evidenced by a significant reduction in the risk of pneumothorax and a marginal decrease in the risk of mortality. Now, amongst animal-derived natural surfactant preparations, there have been studies that have looked at comparison of porcine versus bovine surfactant, and it has been seen that porcine surfactant administered at a dose of 200 milligram per kg phospholipid when compared to bovine surfactant at 100 milligram per kg demonstrated significant reduction in bronchopulmonary dysplasia and the combined outcome of death and bronchopulmonary dysplasia, both by around 30 to 40%. And also resulted in some other benefits, including lower need for redosing, that is, needing a second dose of surfactant or a third dose, lower risk of pulmonary bleed and air-leak syndromes, as well as much lower risk of hemodynamically significant PDA. So we can see all the relative risks in this table. But it seems that the advantage was primarily because of giving higher dose of phospholipid at 200 milligram per kg, or not possibly because of the preparation itself, because most of these benefits could not be reproduced when one compared 100 milligram per kg each of porcine as well as bovine surfactant. Now, while taking a decision of which type of surfactant to use for a given baby, as clinicians working in our country, one also needs to remember cost considerations. One-time cost for a baby who is weighing roughly 1,000 grams, when one chooses to use the bovine lung minced extract surfactant or Beractant alpha, the cost would come to roughly around rupees 6,000, whereas the same if one chooses to give 200 milligrams per kg of porcine, the cost 3 times at around rupees 18,000. So keeping this in mind, one may have to rationalize the use of porcine versus bovine surfactant based on the choice of which newborn may maximally benefit from the use of the higher dose of phospholipid. Although overall cost may be similar, as redosing need for mechanical ventilation or number of days of hospitalization may be lower with the decision that is taken, this needs to be something that is closely to be weighed against the individual cost and clinical considerations. So overall, when we look at the outcome of mortality, as we already discussed, there is no difference between 100 milligram per kg each of porcine and bovine surfactant. When one, however, compared the animal-derived natural surfactants versus the newer generation of protein-containing synthetic surfactants, again, there was no difference with mortality, chronic lung disease, and air leaks. So most of the advantages of natural versus synthetic surfactant were true when compared with the earlier generation of protein-free synthetic surfactants. So coming to the consensus on which surfactant to use, this is what most of the consensus bodies recommend. The European Consensus Guidelines recommends natural surfactant overall over synthetic surfactants. Particularly, they recommend Beractant alpha at an initial dose of 200 milligram per kg. Whereas the American Academy of Pediatrics recommends either animal-derived or protein-containing synthetic surfactants. The World Health Organization endorses the use of animal-derived or protein-containing synthetic surfactants again. So we have discussed so far the need for surfactant, the rationale, the ideal timing for surfactant administration, prophylactic, early rescue, and then we discussed the different types of surfactant. A little bit about the technique of surfactant administration. This again is a huge area of upcoming research now. We have different options starting from Ensure, which came from Scandinavian countries to begin with, which is intubate, give surfactant, and extubate to CPAP. Later, realizing that even Ensure is associated with some risks such as risk of intubation and risk of brief positive pressure ventilation, and knowing that even few high pressure positive pressure ventilation associated with ventilator in BPD, have started looking at lesser invasive surfactant administration techniques, giving rise to LISA and MIST more and more in the recent times. And we also have now studies looking at surfactant administration using nebulization and laryngeal mask airways. Now, one compares the earlier studies which compared Ensure versus continued mechanical ventilation. Ensure seemed to be associated with a lower need for ongoing mechanical ventilation from 3 randomized control studies. Um, Although even Ensure came with some problems associated, as we said, with intubation, interruption of CPAP, because we will be passing the endotracheal tube across the glottis, and hence a closure of glottis that generates the natural PEEP is interrupted with. There is a brief posture pressure ventilation by using high pressure breaths, and Ensure may sometimes be associated with the need for sedation, which inhibits spontaneous breathing. So then came a lot of interest in different types of minimally invasive surfactant technique. Here we see one of the techniques being demonstrated with a series of pictures, initially called by different named techniques. This was called Cologne method, where you can see that using the Magel's forceps and the laryngoscope for direct vision of the glottis, one is trying to thread in the either the nasogastric tube in the left side and a stiff vascular catheter on the picture shown in the right side. Because of the difficulties of using NG tube, which may be too flexible and get coiled, people try to use the vascular catheter or the angiocath, which tends to be more stiff. And using these techniques for administering surfactant allows combining surfactant delivery with spontaneous breathing. And the LISA also allows maintain laryngeal function and potential to improve patient comfort by avoiding ongoing mechanical ventilation. So this figure tries to contrast how the glottis looks with the endotracheal tube in situ versus the LISA catheter in situ. So even with the narrowest size of available endotracheal tubes, such as 2.5 endotracheal tube or 2 size endotracheal tube in an extremely preterm baby, one can see that the MIST or the LISA catheter definitely seems to offer much lesser mucosal injury of the area around the glottis. So when one looks at evidence looking at surfactant therapy using thin catheters in preterm neonates, there are close to 16 studies that have looked at surfactant administration with the MIST or the LISA techniques versus the regular Ensure technique. And there are a number of benefits that have been kind of listed in the meta-analysis, including reduction in bronchopulmonary dysplasia by almost 41%. Need for ventilation in the first 72 hours is again lesser by 37%. Reduction in mortality, reduction in severe grades of IVH, and reduction in bronchopulmonary dysplasia among survivors. Most of these benefits have also been substantiated by the Indian NNF guidelines, CPG guidelines published in 2021. So most European, American, as well as our current Indian NNF guidelines seem to recommend that there is moderate to strong evidence in favor of using minimally invasive surfactant administration techniques. Definitely something that is becoming more and more popular, as can be seen in this study. A survey of use of LISA in neonates born below 30 weeks. And it has also been seen that training using theory and practical demonstration made the learning easier, as in 79% of the providers. There are multiple YouTube videos demonstrating these techniques that can be easily accessed. Differences in practices do continue to exist with regards to the type of pre-medication, such as atropine, opioids, or ketamine that may be used along with the procedure, and the type of catheter that is used, ranging from a feeding tube to a stiff vascular angiocath catheter or a suction catheter in some cases, the route of insertion, nasal, oral, or the use of Magel forceps versus not using Magel forceps, etc. So this much about the different techniques in the in surfactant administration. And even with LISA, there have been studies looking at predictors of LISA or MIST failure, particularly newborns with a gestational age below 28 weeks, elevated C-reactive protein, or absence of complete course of antenatal steroids, or infants receiving surfactant dose below 200 milligram per kg, or developing hypothermia before MIST therapy, are found to have higher risk of failure of MIST or minimally invasive surfactant administration. So a word about the use of laryngeal mask airway, which is again an upcoming mode of surfactant administration. This requires optimal positioning of the laryngeal mask airway, snugly covering the epiglottis, and instilling surfactant in 2 to 4 aliquots. Each alicot would be followed by brief intermittent positive pressure ventilation with the TPs, ensuring that is also being delivered, and after which the LMA can be removed and CPAP can be continued for subsequent management. So this may be possible in level 2 units, as it may not require very intensive training or in newborns with difficulty in intubation. But the difficulty is even the size 1 LMA, the smallest size LMA can be only used in newborns above 1500 grams birth weight. Currently, there are limitations still in the routine use of laryngeal mask airway in preterm VLBW newborns, and it has also been seen that there could be a risk of surfactant getting into the gastrointestinal tract, and it has been seen that around 8 to 15% of surfactant was actually recovered from the stomach in up to 50% of neonates who had received surfactant using a LMA, and hence it is not currently kind of recommended with most of the clinical protocols. So finally, we shall be discussing the non-RDS uses of surfactant in conditions other than respiratory distress syndrome. Here, there is some evidence about the role of surfactant replacement in meconium aspiration syndrome. We know that meconium components, cholesterol, and bile acids change the velocity and the ultrastructure of surfactant fragment and result in inactivation of the most active moiety, which is dipalmitoyl phosphatidylcholine. Meconium also decreases the level of surfactant proteins A and B and may harm the type 2 pneumocytes. So with this rationale, there were studies that looked at surfactant replacement therapy in newborns with established MAS requiring ventilation, particularly with FiO2 requirement beyond 50%, with radiological evidence of significant atelectasis, or what we call white lungs in meconium aspiration syndrome, with the hope that it may kind of improve hypoxemic respiratory failure. Clinical studies, although they did not show reduction in mortality in neonates with established MAS, it did translate into some improvement in oxygenation, resulting in the need for ECMO. Bolus surfactant reduced the need for extracorporeal membrane oxygenation, shortened days of ventilation, and reduced the duration of hospital stay. So there may be a role for surfactant if FiO2 requirement crossed 40% on invasive ventilation with a MAP more than 7 centimeters of water, with evidence of RDS on the chest X-ray, even in neonates with established meconium aspiration syndrome. In newborns with significant component of sepsis or asphyxia, one may consider lowering this threshold to around 30%, but one has to remember that one may not want to try more than maximum of 3 doses in this condition, with allowing substantial gap between the doses. And the type of surfactant that is recommended, studies have looked at porcine versus baractant, which is bovine lung mince surfactant, with the usual protocol, baractant being given at a gap of 6 hours, and porcine might be given at a gap of 12 hours if the neonate continues to satisfy the clinical criteria based on the need for respiratory support. Looking at late preterm neonates between 34 to 36 weeks of gestational age, the NNF-CPG surprisingly did come up with a recommendation in this group, because we do see a large number of late preterm neonates with RDS, particularly in our country, as well as sometimes even early term neonates born at 37 to 38 weeks of gestational age with RDS, who may have been born by either elective cesarean section or by other mode of delivery, but may satisfy the criteria for surfactant administration, clinical evidence of RDS, and may require CPAP with a PEEP of more than equal to 6 with FiO2 beyond 40%. So if one feels that this baby's radiological picture is compatible with RDS, and if they satisfy the need for respiratory support, PEEP more than or equal to 7, FiO2 more than 40%, the NNF does endorse the role of surfactant even in this group. So I'll conclude with these take-home messages. When it comes to the timing of surfactant, there seems to be no longer a strong role for prophylactic surfactant, except in an occasional newborn who is born preterm at a gestational age below 26 weeks, or a newborn between 26 to 28 weeks who requires delivery room intubation with prolonged requirement of positive pressure ventilation in the delivery room, or intubation for RDS. Early rescue surfactant after stabilizing the baby with CPAP seems to be the best strategy at present. Newer modes of surfactant administration, particularly less invasive surfactant administration, have been found to be associated with lower risk of the combined outcome of mortality and bronchopulmonary dysplasia, as well as air leaks and the need for mechanical ventilation when compared to the traditional strategy of intubation and surfactant administration. And units need to gain more and more expertise with newer techniques, as it seems to be the upcoming way to go. And porcine surfactant, when it comes to comparison among different types of surfactant, porcine surfactant at 200 milligrams per kg seems to offer some clinical benefits when compared to 100 milligram per kg of either of porcine or bovine surfactant. And natural surfactant may fare as well as the newer generation protein-containing synthetic surfactants, but more and more evidence on this front is awaited. Thank you all for joining us. And if you have any questions, you can leave it on the comment section.